Okay, super tired, but let's get it.
A 59-year-old man comes to the office with a 3-month history of persistent writer pain. He has tried to control the pain with acetaminophen and ibuprofen, but with no improvement. He has no other medical issues. He works as a welder and has smoked a pack of cigarettes daily for 40 years and drinks a case of beer each weekend. Vital signs are within normal limits. Right ear examination shows a normal external ear, normal external auditory canal, and a clear tympanic membrane with no middle ear. Fluid. Palpation of the temporomandibular joint elicits no tenderness or crepitus. His left ear examination shows no abnormalities. Oral cavity examination shows poor dentition, but there are no ulcers. The tonsils are not enlarged, and posterior pharyngeal wall is non-erythematous. There is a non-tender 2 cm lymph node on the right side of his neck. Which of the following is the best next step in management of this patient? Otalgia in the setting of a normal ear examination is likely referred pain. Pain perceived at a different site than its true origin. The most common causes of referred otalgia are dental disease and temporomandibular joint disorders. However, referred otalgia is commonly a presenting symptom of mucosal head and neck squamous cell carcinoma, HNSCC, especially in an older patient with a history of smoking, alcohol use, occupational exposure to welding fumes, and cervical lymphadenopathy. Referred pain frequently occurs when nerves travel in close proximity, especially if their cell bodies are located in the same ganglia or they synapse in the same location. In this case, the glossopharyngeal nerve CN9, which has afferent fibers innervating the base of the tongue, also has a branch that provides afferent sensory input from the external auditory canal. All of these afferent fibers converge in a ganglion just prior to entering the jugular foramen. Similarly, the vagus nerve, CNX, which innervates parts of the larynx and hypopharynx, also provides sensory innervation to the external auditory canal. Therefore, referred otalgia can be due to a tumor at the base of the tongue or from the larynx hypopharynx. Flexible laryngopharyngoscopy would likely identify the primary tumor site. In a patient with risk factors for malignancy, ear pain with a normal ear examination may be referred from the base of the tongue or hypopharynx larynx. Associated cervical adenopathy makes head and neck squamous cell carcinoma the most likely diagnosis. A 48-year-old man comes to the emergency department due to 3 days of nausea and vomiting. For the past 4 weeks, the patient has also had increasingly severe headaches. He had a kidney transplant 2 years ago for glomerulonephritis and takes immunosuppressants. Temperature is 38.2 C, 100.7 F. Blood pressure is 140/90 mmHg, and pulse is 70/min. The patient is awake but drowsy. Examination shows neck stiffness. Cranial nerves are intact. Muscle strength is normal, but deep tendon reflexes are brisk. CT scan of the head shows no other abnormalities. Results of cerebrospinal fluid analysis results are as follows.
You're not recording, are you?
No, baby, no. Totally am.
I just want to make sure that, like, if you were.
Which I am.
Oh, okay. Am I being too loud?
No.
Okay. Good.
No. There's no way. Fuck me, bro.
This patient's progressive headache, vomiting, low-grade fever, and nuchal rigidity raises suspicion for meningitis. Most cases of meningitis are caused by common bacterial pathogens, egg, Streptococcus pneumoniae, Neisseria meningitidis. However, these organisms typically cause severe, life-threatening manifestations within hours or a few days of inoculation, choice C. In this case, there are several features that suggest cryptococcal meningitis, including the following. Toxoplasma encephalitis typically presents over weeks with headache, focal neurologic deficits and/or seizure. CT scan of the head generally shows numerous ring-shaped lesions in the brain parenchyma. Most cases occur in patients with advanced AIDS. Patients with severe immunosuppression, egg AIDS, solid organ transplantation, immunosuppressant medications are at increased risk for cryptococcal meningitis. Most cases are marked by subacute, progressive headache, vomiting, fever, and nuchal rigidity. Cerebrospinal fluid typically shows lymphocytosis with a mildly elevated white blood cell count, mild protein elevation, and low glucose. One, two. A 34-year-old woman comes to the office due to a 6-month history of easy bruising with minimal or no trauma. She also has had difficulty climbing stairs due to muscle weakness and frequent nocturnal muscle cramps. The patient has experienced a 7 kg, 15 lb, weight gain despite following a restricted calorie vegan diet. Her medical history is notable for an uncomplicated root canal procedure 6 months ago, but is otherwise unremarkable. She takes no prescription or over-the-counter medications. The patient is not currently sexually active and has never been pregnant. Her last menstrual period was 3 months ago. There is no family history of bleeding disorders. Her blood pressure is 146/94 mmHg and pulse is 78/min. BMI is 29 kg/m2. Examination shows facial plethora with dark terminal hair on her upper lip and chin. There is inflammatory acne on her face and back, extensive tinea versicolor on the trunk, and scattered bruises over the extremities. Fasting laboratory results are as follows. A 26-year-old woman comes to the office requesting referral for breast surgery. She says, "I feel disgusted with how my breasts look," and she describes numerous cosmetic aspects of her breasts that she finds troubling, including their asymmetry, shape, and small size. The patient says she has stopped going out with her friends because everyone stares at her breasts. She spends 1 to 2 hours every morning trying on different outfits to hide her chest and has ordered multiple custom bras to make her breasts appear more symmetric. The patient has no history of medical or psychiatric conditions and takes no medications. Vital signs are within normal limits. On physical examination, the breasts appear normal in symmetry, shape, and size. There are no palpable breast lumps or axillary lymphadenopathy. The patient says, "I really think cosmetic surgery would help me feel normal again." Which of the following is the most appropriate initial response to this patient's concerns?
Oh my fucking god, I hate this question. I hate you. The answer is right here.
The most appropriate initial response would be to acknowledge the patient's distress and focus on the impairment it causes without validating or dismissing the patient's beliefs about appearance. Initial response. Initial response. A 22-year-old woman comes to the emergency department due to abdominal pain. The patient has had intermittent abdominal pain for the past 2 days, but today the pain has worsened and become constant. She has had no nausea, vomiting, or change in bowel or bladder patterns. The patient's medical history is significant for sickle cell disease, for which she is prescribed hydrocodone as needed. She began taking multiple hydrocodone tablets today when the pain got worse, but had only minimal relief. Her last menstrual period was 4 months ago, and she has multiple sexual partners. Temperature is 37.1 C, 98.8 F. Blood pressure is 130/88 mmHg, and pulse is 90/min. The abdomen is diffusely tender to deep palpation. There is no rebound or guarding. On pelvic examination, the uterus is enlarged and non-tender, and the cervix is closed. The remainder of the examination is unremarkable. Pelvic ultrasound reveals an intrauterine pregnancy at 12 weeks gestation with a fetal heart rate of 160/min. Bilateral adnexa have normal Doppler blood flow. Which of the following is the most likely cause of this patient's presentation?
Did you check this morning if the cat ate the food?
I did, but I'm like, the thing was empty, but I don't know if like, I don't know, other animals got into it,
Yeah.
but it was empty. So
But half full, Michael. It was hungry.
right.
This patient at 12 weeks gestation with abdominal pain is likely having an acute pain episode, i.e. vaso-occlusive pain crisis. Due to sickle cell disease, SED, acute pain episodes are more common in pregnancy, likely because of increased metabolic demands and a hypercoagulable state. Although the incidence typically increases with gestational age, acute pain episodes can occur in the first trimester, especially if there are other precipitating factors: egg, stress, nausea, vomiting, dehydration. Acute pain episodes can last from hours to days and commonly involve the chest, abdomen, as in this case, or long bones. Pain occurs due to repetitive red blood cell sickling, which causes microvascular occlusion, decreased perfusion, and tissue ischemia. Abdominal tenderness management is with fluid resuscitation and opioid pain control. Round ligament pain, caused by the ligament being stretched by the gravid uterus, typically presents as a sharp pain that radiates to the vagina, not as diffuse abdominal pain. A 23-year-old woman, gravida 1 para 0, at 12 weeks gestation comes to the emergency department for vaginal bleeding after intercourse. The patient had intercourse 12 hours ago and has since noticed blood in the toilet after urination and bright red blood on the toilet paper. She has no medical history and takes no medications. The patient reports occasional alcohol use prior to pregnancy but no history of tobacco or illicit drug use. Blood pressure is 120/70 mmHg and pulse is 65/min. Fetal heart rate is normal by Doppler ultrasound. Pelvic examination shows normal external genitalia and a thick, yellow malodorous discharge in the vagina that is tinged with blood. The cervix is closed and bleeds after being touched with a cotton applicator. No masses are noted. Bimanual examination shows an enlarged uterus but no cervical motion tenderness, adnexal masses, or tenderness. Which of the following is the most likely diagnosis in this patient? One, two. A 38-year-old woman, gravida 5 para 5, is evaluated for difficult and painful ambulation on postpartum day 1. The patient has no pain while lying down, but reports sharp lower midline abdominal pain that radiates down her legs while ambulating. She has voided twice without difficulty and has no dysuria. She has past flatus, but has had no bowel movement since delivery. She has not had numbness or foot drop. The patient received epidural analgesia during labor and had a vaginal delivery of a 4,400 9 lb8 Oz infant that was complicated by a shoulder dystocia relieved by the McRoberts maneuver and suprapubic pressure. Temperature is 37.2 C, 99 F. Blood pressure is 120/80 mmHg. Pulse is 90/min and respirations are 18/min. Neurologic examination shows normal strength, sensation, and reflexes of the lower extremities. Abdominal examination shows focal tenderness to palpation just inferior to the bladder. Pelvic examination reveals normal lochia, no vaginal masses, and a non-tender uterine fundus just below the umbilicus. There is moderate edema bilaterally in the lower extremities, but no pain or erythema. Which of the following is the most likely diagnosis in this patient? A 7-month-old girl is brought to the office due to decreased use of her left arm. Her parents have noticed that the patient grasps objects only in her right hand, and she keeps her left hand clenched. She also does not use her left arm to push her chest up while lying on her abdomen and is not rolling over. The patient was born at 31 weeks gestation to a 25-year-old primogravid woman who received corticosteroids, tocolytics, and magnesium sulfate for preterm labor management. The mother had inconsistent prenatal care and works as a receptionist at a veterinarian office. Today, the patient's head circumference, weight, and length are at the 50th percentile. Examination shows increased tone in the left upper and left lower extremities. Brachial and patellar reflexes are 3+ on the left and 2+ on the right. Tapping of the left Achilles tendon elicits multiple beats of clonus. Babinski reflex is present bilaterally. Sensations appear intact bilaterally. MRI of the brain shows white matter. Injury adjacent to the right lateral ventricle. Which of the following most likely contributed to this patient's condition? This patient has an early hand preference, upper motor neuron signs, and MRI findings consistent with cerebral palsy CP. CP is characterized by non-progressive motor dysfunction due to neurologic injury, most commonly in the setting of prematurity. Premature infants are at greatest risk for CP due to ischemia and necrosis in the poorly perfused area adjacent to the lateral ventricles, which is seen as white matter injury. I paraventricular leukomalacia on brain MRI. These patients may also have friable germinal matrix vessels that predispose to intraventricular hemorrhage. Cerebral palsy is a non-progressive neurologic injury that most commonly occurs in premature infants with paraventricular leukomalacia. Findings can include motor delay, early hand preference spasticity, and hyperflexia. A 4-year-old boy is brought to the clinic due to fever for the past 5 days. He has also had a cough productive of yellow-green mucus. The patient had pneumonia a year ago that required hospitalization for hypoxia. Currently, he takes no daily medications, other than acetaminophen is needed for fever. The patient has received all of his vaccinations except for an annual influenza vaccine. His family is originally from Peru, but he was born in the United States and has not traveled outside of the country. Temperature is 38.9 C, 102 F. Blood pressure is 90/60 mmHg. Pulse is 112/min, and respirations are 20/min. Pulse oximetry is 99% on room air. His weight is at the 75th percentile, and review of his medical records reveals that he is growing well. Physical examination reveals a young child with moist mucous membranes, RALs, and decreased breath sounds over the left lower lung, and comfortable work of breathing. Chest X-ray demonstrates an opacity over the lower left lung with minimal layering of fluid on lateral decubitus film. Which of the following is the most appropriate next step in management of this patient? This patient presents with a history and radiographic findings suggestive of pneumonia and a parapneumonic pleural effusion. Pleural inflammation secondary to bacterial pneumonia can lead to leakage of exudative fluid into the pleural space. Patients may present with symptoms of bacterial pneumonia, ague, fever, cough. An examination usually reveals focal rolls, decreased or absent breath sounds, or dullness to percussion over the affected area. Children with small effusions may be breathing comfortably with normal vital signs, although those with moderate to large effusions typically exhibit signs of respiratory distress, ague, grunting, nasal flaring, subcostal retractions, tachypnea, and hypoxia. Although the diagnosis can be suspected from history and physical examination, chest X-ray confirms the presence of pleural fluid, ague, obscuring of costophrenic angle, layering fluid on lateral decubitus film. For small pleural effusions in patients without respiratory distress, such as this patient, management includes oral antibiotics and close follow-up on an outpatient basis. A 40-year-old man is evaluated in the hospital after being admitted for acute alcohol-induced pancreatitis 24 hours ago. He has been receiving aggressive intravenous hydration and pain control over the past 2 hours. The patient has become increasingly restless and now reports difficulty breathing and abdominal distension. Blood pressure is 80/60 mmHg. Pulse is 122/min, and respirations are 28/min. Heart and lung sounds are normal. The abdomen is significantly distended and tense. Bowel sounds are decreased. Bilateral lower extremity and flank edema are present. Chest X-ray reveals basilar atelectasis, but no other infiltrates. His urine output has markedly decreased over the past 2 hours. Which of the following pathophysiologic changes are most likely present in this patient at this time compared to a few hours earlier? This patient has been receiving aggressive fluid resuscitation in the setting of acute pancreatitis, an inflammatory condition that can cause abdominal swelling from visceral edema, intra-abdominal third spacing of fluids, and ileus, evidenced by decreased bowel sounds. Now, he has a tensely distended abdomen and clinical signs concerning for abdominal compartment syndrome, ACS, including difficulty breathing, and basilar atelectasis, from diaphragmatic elevation causing lung compression, and decreased urine output from increased intra-abdominal pressure reducing renal perfusion. ACS occurs when a rise in intra-abdominal pressure, IAP, reduces abdominal organ perfusion to the point of causing organ dysfunction. Because elevated IAP is transmitted to the thoracic cavity through the diaphragm, ACS also has significant cardiovascular consequences. The increased intra-abdominal and intrathoracic pressure seen in abdominal compartment syndrome can cause significant cardiovascular consequences, including venous compression with increased central venous pressure, decreased venous return to the heart, decreased cardiac preload, and decreased cardiac output.